Um, okay, hello everybody. My name's Tom Manley. I'm a gynecologist and I work at in the southeast of Melbourne, and I work at Monash Medical Centre in the laparoscopic surgery unit, and also at the Royal Women's Hospital in the reproductive services unit. And so most of my training is around treatment of women with things like endometriosis and trying to optimise fertility in young women, particularly leading into pregnancy and health throughout pregnancy. So I also deal with pregnant women throughout their pregnancy and delivery and look after them after they're pregnant and when they're recovering from childbirth as well. So my expertise is around endometriosis really, and I think we're going to talk about that now.
We are. So thank you, Tom, for introducing yourself. I was going to introduce you. That's okay, though. Well, I had this really great introduction spiel for you because I'm going to say that Dr. Manley is a specialist gynecologist, obstetrician, fertility specialist with Melbourne IVF, and an advanced laparoscopic surgeon. Do you agree?
Beautiful. That's a good summary. Thank you, Kathy. That's great.
Okay, so yeah, we're talking about endometriosis today. So do you want to start with what is endometriosis?
So I think endometriosis has come up in the media a little bit more recently. It's a condition that has been around for a long time, and we really, from the point of view of how it gets where it is and how it starts, we know very little about it, but it affects between about 5 and 7% of young women. So lots of women walking around the street that you might see have endometriosis, and it affects women differently. So usually there are two reasons why we might find out about endometriosis. One is pelvic pain, and that can be related to periods or during normal life. Women might get the onset of pelvic pain. The other one is fertility, so it can impact the chance of getting pregnant. But having said that, most young women with endometriosis just get on and get pregnant without needing assistance. And most women with endometriosis don't have many symptoms, but lots of women with endometriosis have severe pain or problems getting pregnant. They're the main two things, I think.
Okay, so is there any risk factors for having endometriosis? There's no way of knowing, like, is it hereditary, or at what age do the people that are getting it tend to be?
Yeah, we think that there is definitely a genetic component. So I definitely see mothers who bring their daughters in, or sisters who seem to both have endometriosis. It usually starts in late teens or early 20s, and is something that can slowly evolve over time. So it usually can start with painful periods, and sometimes they get worse to the point where you need to seek advice and sometimes have surgery. The genetic component to endometriosis is not well understood, but certainly I see families that come in with it. We know that the more periods young women have, the worse endometriosis can get. So fundamentally, the other risk factors relate to that, basically. So the more use of the oral contraceptive pill we see in young women, the less we see endometriosis. And also the more times a woman is pregnant in her life, the less impact endometriosis has. So most of the treatment around endometriosis is actually trying to minimise how many cycles somebody has.
Okay. And is it something like that later in life the symptoms disappear?
Endometriosis definitely is driven by ovarian function, and ovarian function is obviously very strong in the 20s and 30s, and then as you get into your 40s and closer to the change in life, which we call menopause, endometriosis settles down. So usually it's a disease of mid-20s to mid-30s, and then things settle down as you get closer to 40s. And once a woman goes through menopause, endometriosis is cured. It disappears.
Okay.
Yeah.
Okay. So what are the treatment options for endo? You've said obviously maybe putting them on the pill. What are the other options for treating it?
Yeah, absolutely. So trying to suppress growth of endometriosis is best done with hormones, and the easiest access to hormones is the combined oral contraceptive pill. You can also use things that release progesterone. So an example of that might be the Mirena IUD, which was originally used as a contraceptive device as well, but also works really well in suppressing endometriosis. The other option for treating endometriosis is basically moving on to surgery. And I'm absolutely talking from a medical point of view at the moment, but I'll touch on some other things as well. But so from a surgical point of view, keyhole surgery is something that I specialise in, and that's looking in the pelvis and physically removing the spots of endometriosis that grow in the pelvis. There is not as much evidence around complementary medicine and diet and lifestyle, but I think that's absolutely a really important component to all of this, because I do see that women who are healthy and active and take an active part in their health find that their endometriosis doesn't affect their quality of life as much, which is really important, and that's where somebody like you, Kathy, comes in.
Okay, great. So with it, how is it actually affecting fertility?
So from 2 points of view, I think endometriosis, if it can certainly cause scarring in the pelvis, and if that scarring is severe enough, it can affect the function of the ovaries and the fallopian tubes, which are really important for carriage of the egg into the womb. That's one thing you wouldn't be able to find out unless you went and had some surgery. The other effect we think is to do with inflammation. So the endometriosis causes quite a bit of inflammation in the pelvis, and the release of those inflammatory factors is inhibitory to implantation of an early embryo. It's not black or white. It doesn't mean it will or won't happen, but it can affect it. So we estimate that somebody with endometriosis has a decrease in their fertility of about 10%. So it's not an absolute thing, but it does have some effect.
Okay. And what recommendations would you be recommending to couples who are facing infertility and have endometriosis?
I think definitely when we talk about fertility, there's multiple factors at play, and you can never discount other factors that might be affecting fertility. So I think a really important first step is to sit down with a specialist or somebody who can spend some time teasing out the couple's fertility situation. And certainly if there is endometriosis known and a couple's been trying naturally for more than 6 months, then we should be investigating further. So away from strictly talking about endometriosis, there are some other tests that would be important, including a semen analysis. But if we do these other tests and we don't find a cause, then I would suggest that removing endometriosis surgically can optimise natural fertility. And then if that is unsuccessful over the next few months, then there's a possibility of couples needing to access things like IVF.
Okay, cool. Excellent. So that's a lot of great information you've given us today. Is there anything else that you would like to touch on or add to what you've already said?
I think endometriosis is really not well understood. So most of our work from a research point of view is trying to work out why some women have endometriosis and some women don't. So that's an area that we need to keep working on. But women living with endometriosis need our support, obviously, because it can be a really debilitating condition for young women. So awareness of the disease and treatment options is really important.
Excellent. Well, thank you so much for your time this afternoon. We had a few tech issues at the start, but we got those ironed out. So thank you. It was really lovely talking with you, and I'll catch you soon. Hopefully yeah, now that we don't get to work together anymore. So, right, thank you so much for your time.
No worries.
Thanks. Bye.